Log on, tune in, find out. Another good idea from Cambridge.
From University of Michigan. And she'll have some comments on all three talks, and then we'll open it for the floor if you still have some additional things to chip in.
Obviously, I'm going to press a lot of wrong buttons here. I heard from my British friends that the Royal Statistical Society does the discussion in a format that the discussant first gets up and struggles hard to find something nice to say about the papers. And then the seconder rises and says that what a load of crap this was. And so I'm going to do, is that right? Because, all right. So I think I'm going to be British here, and Americans are sort of nice, so I'm going to do a hybrid discussant seconder type style here. All right, so what is the story? No other session has discussant. Why am I here? So there's some kind of political undercurrents going on here. Peter is the organizer of the session, and basically he said, you know, these people are tough and they are going to say a lot of things. Why don't you get up and say some outrageous things, provocative things, keep the crowd entertained, and basically that's why I was hired. So there's lots of what should I say, relationships here. First of all, the advisor-advisee relationship, which is can be nice and can be tricky at sometimes if you're trying to give talks in the same session and there is a direct comparison. And then, of course, Peter Thal and Yuan Ji, they work in the same institution, MD Anderson, and Peter is obviously much more senior, so there are some undercurrents there as well. And I don't know what Peter is doing here. So sitting nicely, just embarrassing people. So basically, he said hired. So I got hired as a sort of discussant to embarrass them and to also analyze the papers. But you know, when I accepted this invitation, I have been discussant in many conferences. Never had I had 45 minutes of discussion time. I think that's outrageous. And the thing is that you have to, if you are giving a talk, you have to get up there and defend yourself and your own eccentric ideas. And here I am trying to get into the mind of three people. So it's a lot of work. So let us think about papers 1 and 2, because they had the same sort of theme about covariance adjustment and covariate adaptive designs. So the first paper was Bayesian covariate. Actually, I'm going to discuss them jointly, Kim and G, the advisor and the advisee, who has graduated, obviously. And so the title of Kim's talk was he was doing covariate adjustment as well as response adaptive designs. And the title of G's talk used to be in the program was From Bench to Bedside. That sounds sexy. And then the application of differential protein networks on Bayesian adaptive design for trials with targeted therapies. And I noticed that he is the senior author there, and how to say he's the presenter, so how to talk about his paper. So I say instead of G et al, it would be et al, comma G. And that et al part is Peter Müller sitting right there, and also Lorenzo Tropa. So he changed this trial, this title, quite an ambitious one, to ARRM, Adaptive Reassessment and Randomization Scheme. All right, so the main theme which I noted was that there are two types of adaptation. One is the response adaptive part of the design, where optimized patient allocation by randomizing patients to the superior treatment based on biomarker profile. And the covariate adjusted, whether you identify subgroups of patients who would respond better to targeted therapy based on biomarker profile and response. And so the new feature, which I thought was very nice of these talks, and all three talks were very interesting in the sense that they address problems, real problems, which people are trying to solve in the clinic. So the biomarker profile groups, the new feature, they are assuming that are initially unknown, they are not pre-specified. So the goal of their talks were to essentially define an intelligent partition on the subspace generated by potentially k biomarkers in a data adaptive way as the trial data accrues. And so the partition actually changes as data is coming in, continuously being updated. So the subgroups are not defined at the onset, which is sort of the classical covariate adjusted design or subgroup targeted designs. Now, most of them considered multiple therapies, J therapies, including targets, and address the question that maybe you do not know the target therapy often does not do the best for the target subgroups. Also, you're learning about does it happen to work for non-target groups as well. So in that sense, it's a very intelligent thing to do, and allowing uncertainty in subgroup definition is a good thing, and you are doing it so that you're extracting information from both patient outcome and the biomarkers in a sequential way as the data is gathered. So that those are very interesting things. So who did better? So this is the so I actually apologize to all three of them, so I think I can say anything. So so who did better? First of all, Kai-Meng talked a lot about, I really enjoyed his introduction because I did not know much about this area, his slides, but then he ran out of sort of time on talking about his own stuff. So he talked about the past and gave a very nice background. Wenjie, he had 20 slides, and when at the time actually when I got it, he had 10. So a lot of his exciting work is under progress, which I have to say. So, and if you look at their background research and their research career, Kahneman always worked on early phase clinical trials. Wenjie did something different in his dissertation work about protein networks, but then he went to MD Anderson and obviously started doing early phase clinical trials after his thesis. So typically in Kim's work, he has been frequentist, but he used Bayesian method for this paper, whereas the student has been Bayesian. So they both adjusted for biomarker profiles by partial least squares logistic for biomarker profile. Kahneman did it. Kahneman did it by looking at biomarker profile by partial least squares, and then Wenjie used a truly flexible, sort of vague Bayesian model to cluster biomarker profiles to define subgroups, and we'll come to that about this why it's flexible but probably a bit vague. So acronyms, from listening through these few days, I think acronyms are really important in clinical trials. Battle, I-SPY, ARMS, and so on. So if you wanted to really push your method, you better come up with a good name. And so BCARA was the acronym for Bayesian Covariate Adjusted Response Adaptive. That was Kahneman's acronym. Wenjie sort of tried to follow the MD Anderson tradition and get into battles. So he had ARRM. And initially when I received the slides, it was ARRA. And in US, there is this funding opportunity, which is and also announcement of America's Recovery and Reinvestment Act. So ARRA reminded me of that. And then I already had the slides prepared. He changed it to ARRM, and I just changed it to method. So this is a very poor joke. So Kahneman's talk had three components. One is the response adaptive part, and then the covariate adjustment part. So Kahneman was looking at a logistic model, response or not response, and he was fitting it with an underlying latent variable framework, and this is directly taken out of his slide. So, and at so the scheme was that he was starting with equal randomization to each arm, and then he was allocating patients in a response adaptive way, that the patient I+1 at the I+1th step is assigned to treatment J based on the posterior probability of treatment J being superior, and given some criteria given biomarker profile X at that time. So, but he did the defining the profile subgroup in a very intelligent way, using partial least squares logistic regression. And the nice thing, as he pointed out, was that it extracts information from both the biomarker and the outcome, instead of doing PCs on the biomarkers and defining the subgroups separately through the biomarkers. So this is a latent variable configuration where you basically have a latent variable model for the biomarkers, and then you regress the outcome on the latent variables, and you do that jointly. And so it is sort of a so the score loadings that you have for each of the components extracts outcome information as well as covariate information, and that's why in an adaptive sense I thought that this was very nice. So and then you use this partial least squares components in order to define the subgroups. So you basically, if you are defining it in terms of one subgroup, you have, if this partial least squares is bigger than 0, then you put in subgroup 1 positive or negative. And if you have multiple PLS components, then you have multiple configurations and you define more subgroups, but you reduce the dimension of the original subgroup because you are doing a data reduction here. So his stopping rule was, again, you pick on treatment J when it is doing better than all other treatments J prime in some sense. And when this probability of getting the superior treatment given a biomarker group configuration is more than exceeds a certain large number of a certain large probability. Now, one thing is, so when you define this, I had a little bit of a problem with the notation, thinking that here he was defining the deltas in terms of indicator variables, that it is 1 or 0, and then in the loss function, he goes on and says that this is equal to G, but the notation probably is that this indicators are giving configuration G after the ith step. It's not really just indicator variables. G is the groups that you could have. So that's a clarification. That will be one of my questions, but I think that's already clarified that it's a notational issue. So as I mentioned, that you are conditioning on the biomarker group, and it was not clear to me that whether his definition of biomarker groups, how it is iterating the process, that you are defining the biomarkers at each step and then doing the Bayesian Gibbs sampler, and how are uncertainty is being modeled in a joint way. So that's one thing that I noticed. So, and you are expecting that drug J is expected to work if you have target G. Does it not work if you do not have target G? He is also getting information about that. So I think that's a good thing about doing this type of flexible covariate defined partitions. So one thing which occurred to me, that there is a literature on doing variable selection simultaneously with this PLS. And so there is a notion of penalized PLS, which is probably you could use to select the features as well as do the defining the covariate subgroups. That may be helpful here. Maybe that is an idea that can be explored. So how to define partitions with more than one PLS components? In the paper, actually, they have ideas about that, whether how to define the subgroups in terms of more, if you have more significant, more than 1 or 2 or 3 PLS showing up. One thing which bothers me in this partitioning things, that when you iterate this partition, each time you're getting a new thing. So what is your end deliverable? What are you telling? Is it the model, the most common subgroup for each patient? What is your, how is uncertainty in this subgroup definition? Is it a measure that you report with that, like this much uncertain? That is something that I did not see in any of the 2 talks, which I think that would be something that I want to know, that whether this is almost always the case that I came up with this subgroup or not. So I think uncertainties with that allocation was something that I'd like to see. And PLS is sensitive to outliers. There are versions of PLS which are robust, and so penalized robustified PLS will probably be another advance on this. So as far as I understand, that the PLS models will actually include interactions between the biomarkers as well. So I do not know which type of trials you are thinking about, phase 2 or phase 3, but if sample size is a problem in doing such a model which captures interactions as well. And that's one comment. So I think I enjoyed reading this paper, and I think this is a very nice idea, but uncertainties about the partition and some of the details are probably something that one would like to look at. So let us come to 1G. So he wanted to do the same thing, to achieve the same objective, that you want to update the biomarker subgroups during the course of the trial as data comes in, and he wanted to do it based on patient's differential response to treatment. So you have a random, so he talked about a random partition of the covariate subspace. So first he does a principal components, and then he induces a random partition on the covariate subspace based on the extracted principal components. So he wanted to get into arms, army. I think he can add a scheme to get it to arms, and which he needs to fight the battle. So, so his setup was that you have Y, your response, given your covariates, and treatment. So the advisor used treatment for a T for patient, and the student used T for treatment, which was a you have to keep that in mind as you look at their slides. So he is going to update treatment assignment. Basically, you'd be in terms of posterior predictive value corresponding to the treatment assigned for the ith patient. Now, and he talked about not just using the posterior predictive, but some functions of it in order to allocate patients. So then he went on, said that in order to do this model, so he needs a model for this of Y given the covariates, the biomarkers, and the treatment. He has two choices. One is to just think about this as a regression model, and both of them are trying to reduce the dimension of the covariate subspace. Think of it's like a variable selection, or first do a PC of the covariates and then try to use that. So, so you basically then write down a model for Y instead of Y given X, Y given CX, which are the principal components, and the treatments. And so how to choose the PCs, and we all have a number, so one decided to go with the magic 5. Then he talks about, this is the part which is not clear to me, that first you extract the PCs, and then you try to define a random partition on the principal component subspace, not on the actual biomarker subspace. That's my understanding. And you have a partition where, given the partition, basically you have probabilities for each corresponding to treatment, and you're writing down the likelihood of Y given X, treatment, and the partition. So there are some, and then you iterate through this process, and he showed an example which sort of bothered me, that you have some prior probabilities on this partition, and you have 50,000 possible subsets to start with. So it was not clear to me that this random partition, when you define it, how is it modeling the dependent structure of the actual biomarkers or the PCs through this CART model that he talked about. In the likelihood of the data, you are looking at Y given X treatment and parameters, or Y X given treatment, partition, and the parameters. So what is the likelihood you're looking at? So if partition is something that you're trying to estimate as well, what is your end deliverable again? Are you giving a partition or a modal partition? What is the ultimate goal as you are iterating through the process? So the extraction of, so one thing I noticed that this two-step methods where you do the PC extraction and then you could do the random partition, probably you can do it jointly as well in terms of a latent variable, and that's probably captures uncertainty in a nicer way. So priors on the random partition, I did not really get a sense of whether the results are sensitive to that. Because you will end up, what type of N and K you are talking about, that you are going to end up with sparse cells, and maybe depending on how flexible you are, identifying too many subgroups. And what is the final use of that? Is it we are talking about phase 2 trials or phase 3 trials, or maybe based on this or a combined trial using both phase 2 and phase 3 information? So what type of N and K are typical? Is it like N of 200, K is 5, so to what extent, which is the situation you're trying to solve. And do the treatment work beyond targets? Do you learn? I think you do learn whether the treatment work beyond the targets in your methods. And how can you ensure that you're selecting the biomarkers that are predictive of the response in this way? I did not see quite the response. So in the PLS in Kahneman's, it was very clear because he was using the outcome and the biomarkers through a model. In this one, it was not clear to me, but maybe I missed something. So, and there was no comparison with alternatives, which is the other two papers exhaustively compared with the counter designs and the possible alternatives. So, but as I said that this is quite interesting work, but ongoing. So that's about it. So he had a slide which I tried to grill, which is based on pathway, how you can define this partition. So how pathway-based information can be integrated into this partition, and I think he has wisely taken it out of his talk. So he did not talk about this, and so, but I got it in the original slides that he sent me, but I think he realized that it's too fuzzy as well. All right, so the third one, Peter Thal, and so it is a very nice paper, and it talks about optimizing the bolus and concentration of a drug administered by continuous infusion, and it's a very nice modeling of efficacy and toxicity targeted to one particular kind of trials, one particular kind of problem. And so if I was nice, I will say that it's highly motivated by the AIS phase 1 trial. If I was not so nice, I'll say, like, is it generalizable? Is it too specific to solving that particular problem? But it's a wonderful solution to that particular problem. There is no doubt about that. The elicitation of utility is as a function of patient outcome. We'll talk a little bit about that. And then prior elicitation and calibration. It is not covariate adjusted, so Peter Müller did not tell him about that, so it's not Peter Thal's fault. So when I asked Peter, and actually I must thank Peter Thal because he sent me the paper, the talk, and what am I supposed to say within like 15 minutes of Peter Müller saying that please send the slides. So he actually helped me a lot. And when I actually asked him that, you know, Peter, what are you going to talk about? So he exactly said this, that my plan is to explain the motivating trial and method and then elucidate its meaning in the context of our position as a species on a tiny planet orbiting a star located at the edge of one of billions of galaxies in the cosmos. And so this is quoted from his email, and I'm not lying. So I was very excited. And so what he talked about was a very nice example of AIS trial, acute ischemic stroke, that you are given an initial dose and the treatment parameter associated with that is Q, what fraction of the total dose you give, typically 0.1 or 0.2. And then if the clot dissolves immediately, then your observed time to dissolution of the clot is 0. And if it does not dissolve, then you give a continuous infusion of this this drug, and then you have the treatment parameters 0.2, 0.3, 0.4, 0.5, the possible choices that he explored. So, and associated with this time to dissolution of the clot, which is a measure of efficacy, there is a toxic event which is SICH, which is a binary variable, and which depends on C, Q, and the time to dissolution of the clot, and then you are monitoring it at every 15-minute interval, as he talked about, and YE is interval censored up to 120, and beyond that it's right censored. So he proposed a very highly parametric joint model for each of these components. For example, the probability that the bolus dissolves the clot instantly, and then for the time, which is a mixture, which turns out to be a discrete continuous mixture because you either dissolve instantaneously or you don't. And then you have a model for the toxic event SICH, where you have a baseline and you have a contribution for the initial bolus, and then the continuous dose, and then the contribution from if it does not dissolve in those 120 minutes. And this is in terms of standardized time. The 120 was scaled to 0 to 1. So he has a complex looking likelihood function where you have the 4 components: dissolving the clot with the bolus at y equal to 0, and then you have the dissolve the clot during some 15-minute time interval. That's the interval censored path, and my arrows did work, right? So it's probably not an America-England problem. So all right. So it's and then there is a component where you have the right truncation and you fail to dissolve within the 120 minutes. So he talked about eliciting a utility function, which I think is one of the signature of the kind of work that is being done in terms of how it's very complex, because you have 2 design parameters and you have to map them to some kind of utility function. And Peter described this very well, that you have patient, the utility is elicited based on patient outcome, but not really elicited from patients but physicians. All right, so you basically take your utility function as a function of the design parameters, and you integrate over the YE and the YT, where the toxic event and the censoring and the censored time, and then you have taken expectation with respect to the prior. So I'll skip this slide because he talked about this and Peter is like showing me 1 minute. So the thing is that eliciting utility. So he had these numbers given on what type of outcome you have, is the adverse event happens or not happens. So each time you put together a belief, then you are, the question is, are you allowed to question them? And of course you are. And is it same for each patient? Do you really, is it an assignment made by the physician which holds for each patient, or should it be changing? I know that's impossible. And then other utility functions, and he mentioned that probably it's a combination of fixed quantities of the information matrix, which is objective, and the subjective. That's probably something interesting to look at. And actually, if I was I almost put down that the futility of utility, but I didn't. So the eliciting priors, and so I find this part actually quite difficult to process, that because you are saying you are eliciting a number of prior parameters, which are talking about the probability of the clot dissolving in 1 hour, 2 hours, how reliably you can do that, and you have 42 things to think about, but probably you can. And the strength of the paper is that it really does a very thorough sensitivity analysis, as Peter mentioned. So the calibration of the prior was very, very good and very interesting, that where you generate the pseudo data of a larger sample size and determine what is non-informative there, and also in terms of the prior means, and translate it back to your actual trial size, which is 36 patients. So that's something quite very interesting about that paper. So a very thorough sensitivity analysis under different configurations of design and model parameters, and as Peter said, that 14 supplementary tables. The models look sort of, the parametric models look highly parametric, but they are sufficiently flexible actually. One question I had, that if I really had covariates in this design, patient level covariates, could we include that in the model somehow? And that probably makes things quite complicated. So in general, when we do this utility based things, and how do we sell or justify it to people? Is sensitivity analysis or robustness is the way, or some kind of other measures that we talk about? We have 11 parameters, 36 patients, sort of non-informative prior from a computational perspective, and also in terms of the results perspective. Are we really asking for too much, for too less? So in terms of the session summary, I think there are some points that all 3 talks are very much in line with what is being pursued in clinical setting, and that makes the talks very real. And I want to thank 2 of the speakers for sending their slides, and thanks to the 3rd one for not sending much. So combining phase 2 and phase 3. For the covariate adjusted designs, I was not so sure what they are talking about, phase 2 and phase 3, or how the data could be modeled in maybe jointly. I don't. are the classical notions of optimality relevant? I did my PhD with William Studden in Purdue, who was a strong believer in optimal designs and the hardcore classical information theory based design. So how to combine these notions with the more objective information matrix based notion of optimality. This is a sticking point whenever I go to the talks. What is the final analysis? What am I telling, what am I reporting after I do the design? Because we talk about missing data, covariate adjustment, definition of this subgroup. What is the final end product once you do the trial? What do you report? And what are the right measures of uncertainty? I think that's something. The final thing, our discussions should never be assigned 45 minutes. And thank you for coming to the session. So, and if you notice this, I'd like to point this out, and I'll not leave the floor without pointing this out, that this is Peter versus Peter. And these are two faces of Peter, and I think that he has done an incredible amount of work in this field, and sometimes, you find your own mistakes and progress through research, and academics is all about fighting with each other and fighting within yourself too. So that with that notion, I'd like to thank you for coming to the session.
Thank you, Bhramar. Thanks for a delightful discussion. Would you mind to leave the microphone?
Maybe yes.
So I said we are starting to run a little late. I suggest we do the following. I'll open the floor for follow-up comments, etc. Like Bhramar opened a few issues. Maybe some of you want to chip in. And then I would like to give the speakers a chance for a quick rejoinder. Like think of what you want to say within 3 minutes in the end, each of you.
I have a very naive question. Why you did not start this session with a discussion?
I think that's a wonderful...
She managed to describe everything in 45 minutes. Three men try to do it.
Bhramar, you're hired again tomorrow. Yeah. Does anyone want to follow up to some of the issues?
You didn't answer.
Because I want to do it even more radical. Next time we start with the questions, yeah? So first the questions, then the discussion.
But actually I have one serious question. And actually it was done by discussant already. All three types of design can be considered as so-called best intention design. So what does it mean best intention? Almost all of them, of the three men, sorry, they try to put each new patient to the treatment which is considered the best accordingly to the current knowledge. Is it correct? Correct.
No, not necessarily, was it?
Yes. Yes, it was.
Yes.
No, you just...
Okay. Okay, with minor variation in the second, I think, second presentation. And that is related to so-called self-tuning optimizers. There is such concept in optimal control. And in optimal control, they know that that type of optimizers do not converge. Or actually worse, they converge to wrong decision. And my question to all three presenters, did they address this problem? I understand that nobody talked here about sample size of infinity or something, but nevertheless, this problem somehow should be addressed. And people do in optimal control some tricks which allows to avoid this thing. And it seems to me one of the speakers really tried to do this. I will not say who tried to do this. Maybe we ask discussant, so she knows, I am sure. So, but the question to all three men about this phenomenon.
So that's a very pointed question. Do you want to answer that? Peter, 1 minute.
Okay, so quickly, I've got a couple of ways to address them. One I mentioned is that what I'd like to do with this and similar designs is make the utility function a mixture of the patient outcome utility, the information utility. The other thing that we've started to do with utility functions like this is when the utilities of more than one treatment are acceptable and within, let's say, delta, or epsilon, if you will, of the optimal, that is, they're not too far away, randomized adaptively among them. And we've just finished a manuscript in another setting, radiation for pediatric brain tumors, but we discovered that actually over the course of the trial, that does better than just picking the optimum in a myopic way.
Yeah.
So
That's
we
what they
discovered
could all
empirically
do.
what Dr. Fedorov knows.
So that was a partial answer to the best intention design.
Yes.
Any of you
Yes.
want, please?
Well, in terms of the convergence issues, I mean, we have that criteria for stopping that process. And
You
my
never converge, you stopped.
Right. So that's why we have the maximum sample size. The type of studies, I mean, you raised that. Type of studies that we're considering is very small phase 2 kind of investigation, between the sample sizes of 30 to 50 at most. It really as a sort of a discovery exercise. And so that's the question to your
You
answer.
still don't want to get caught like ECMO in the wrong treatment,
Right.
right?
So you stop to run before
Right.
you see, if you continue to run, you find out that you actually ran to the wrong direction. So-
Right. So we sort of end the trial with sort of inconclusive results in terms of picking the quote unquote.
Yeah, I like Peter's response better because actually what should be done, it should be done, you see some kind of combination on information and best intention, then you are done.
So we are starting to run short of time. So maybe like a few more comments if you have what you want to add to the questions for the speakers. Yeah.
I would like to answer Bhramar's question about how you determine the situation where you have G greater than 2. It's not a very trivial question, actually. You probably have to come up with some sort of a metric to sort of define that, because at the end of the PLS sort of exercise, you get score loading. So that's the first answer. The
But can we wait with answers? Like in the end, I give each of you 3 minutes. Yeah. Just if anyone else in the audience has something to add, Jeremy maybe.
So just a comment, two comments on the first 2 papers. It struck me that they were more about trial management systems to allocate patients in a way which made them a little more ethical. And it wasn't necessarily relate to how you'd analyze the data at the end.
Right.
Is that okay? That could be completely different at the end of the day. So that's
a
one
good
comment.
answer.
And then I guess somewhat related to that then is you both had groups, but you actually don't need groups. You just need covariates to predict out probabilities, and you can do away with the groups, considering you only put groups in because you thought that was what you wanted at the end, but you weren't delivering something at the end anyway. So why not just use covariates?
Good point. Any other thoughts you want the speakers to address in their last few minutes?
That was my word too.
Please, Franz.
Yes, still the question about Bayesian versus non-Bayesian. I'm sorry, perhaps it's too late.
Oh, it was actually neat.
No, because it seems that in your talk you were Bayesian just because it was more helpful or more easy to compute posterior probability. But if you have a first stage of 100 patients, you can learn what are the probabilities. Not being Bayesian, you could be a frequentist and do it the same way. And my second question is, what do you do to analyze the data? Do you do any test at the end, any p-value, or? It was not very clear for me.
It is social, his student worked for Andy Anderson.
Yeah.
So maybe that's a good time to pass it on to the speakers. So each of you, like 2-3 minutes. Jan, you want to start?
Okay, so I will first address, thank you, it was great, and I'm sorry I didn't send the slides in time.
I didn't name you.
No, it was obvious. But when you come to the slide or whatever, so people can hear you
And
better.
you got soft.
In the end, so I was disappointed.
Sorry.
So I think I first want to address Jeremy's question because it also came out during the talk. And the quick answer is at the end of the trial, you would want to do a final analysis and come up with a fixed rule, and that's the type of rule you would apply to, for example, phase 3 confirmatory trial. And that rule would be if the biomarker is less than certain things, as simple as that, and then you'll use treatment X. So that would be the type of rule at the end of such a trial. But I hesitate to do it on a small phase 2 type of trial because you really need big sample size to be even firm to move to phase 3. And just a couple quick answers to Bhramar's questions. I think you mentioned about the sparsity of the subsets, and there is actually a control of that. in the Bayesian card. So the number of a subset B must, the size of that has to be greater than 30 in our implementation. So that was already thought about. And finally, the sensitivity about the partition. I thought that's exactly why we do random partition. And then I mentioned the P's and Q's. So in the simulation, the P's and Q's are kept objective in the sense that P's are 1/5. We magically have 5 principal components, and Q of the split is half and half. So that was the, I didn't mention that, but that was implemented in the simulation.
Thank you. Kyungman?
Well, I'd also like to thank Bhramar for a very entertaining discussion of the paper. But getting to your question about the situation where really G is greater than 3, I think it probably requires some serious sort of understanding of the process. Just looking at the problem, I don't have a quick answer. The only thing I can think of is you have that first load and just divide them into, say, equal parts, or using some sort of scale, or some probability measure. That's something that comes to my mind. Most of these trials, they are really targeting certain markers, some pathways. So for practical purpose, for the type of trial that we are in the process of sort of hoping to conduct, is really looking at two groups. Is this group, there is really a subgroup that will respond favorably to the treatment that we are looking into, or not? So at least we have a sort of an immediate solution, but that's a very relevant question. Is there really more than 2 groups, sensitive versus non-sensitive, or there's some gray scaling in that grouping? And I don't have a clear answer to that.
And so you're not really providing uncertainties about the groups, identified subgroups either. You're just saying like that this is the most common group for this patient that came up.
Thank you. And last speaker, Peter, 2-3 minutes.
So I would like to thank my esteemed colleague, Dr. Mukherjee, for her very incisive comments. I think patient-specific utilities is a great idea. It's a lot more work. We actually have done that in the trade-off based design in the 2008 paper, if you consider that to be a utility. I absolutely think covariates ought to be included. That's a lot more work. The covariates here would be age and NIH stroke score. I asked the investigators, could we please do that? They said no. In this trial, it's a rare instance where there's absolutely no dependence on accrual rate because you have every patient's readout within 48 hours. In oncology trials, that's not the case. And lastly, I'd like to apologize for not coming up with an acronym, so I have. I thought it was both, Bayesian optimal adaptive treatment of stroke, but it turns out it's not optimal. So the actual acronym for this is BATS.
Thank you. So, thank you to all the 3 speakers and our discussant, and thank you for joining the fun. See you tomorrow. Thank you.